Please join me in welcoming Caitlin.
Thank you, Bianca. Good afternoon, or wherever you're at. Maybe good morning, good evening, whatever time of day or country or time zone you're in. I know, is everybody able to hear okay? Because it seems like chats were popping up about sound kind of being off. Okay, I got a thumbs up.
Okay, that's a thumbs up.
Okay. So hopefully that means overall it's okay. Great. Thank you. Well, thank you for spending some time with me today, everyone. I'm really looking forward to talking about this topic. It's something I'm very passionate about. And they're hearing me twice. I don't know how to do anything with that. Oh, no. I am not the IT department. I can't help you. Oh, no. That's why I have Cindy and Bianca to hopefully help. So I really appreciate you introducing me, Bianca, as well, too. Man, sometimes when I listen to that, I'm like, wow, I actually kind of know what I'm doing. It's crazy. So, all right. So I'm going to go ahead and jump right in. But my hope for today is that hopefully I get some discussion or questions that pop up. I really enjoy being able to have a discussion rather than you hearing me just talk at you for an hour. I feel like that's probably not always exciting just to sit here and listen to a lecture, right? So today I want to talk to you guys about military sexual trauma amongst male service members and veterans as well. Where I work at the Claudia Black Young Adult Center, we see a lot of active duty young adults here. So this is something we actually see quite a bit.
But he doesn't even have a primary care to follow through, and he didn't like the way it made him feel anyway.
All righty. And let me make sure my computer wants to start clicking. All right. And we can see everything on here. Hopefully I'll get a thumbs up. Okay, cool. So I know Bianca already talked a little bit about me, so I don't need to give you too much of a background. But currently I do work at the Claudia Black Young Adult Center. We see 18 to 20s. We've seen up to 29, 30-year-olds. So it's pretty wide range of young adults that we see. And we're very fortunate that we are in network with TRICARE and get to work with our active duty service members. A little bit more about me and why I'm so passionate. You know, I was raised by an Army veteran myself. So my dad really raised me to be very involved in a lot of his veteran activities. We would go to Washington, D.C., talk to service members in Walter Reed Hospital, just to go visit them during their healing journeys there. So it's been something that's really been a part of my whole existence and growing up, I feel like. On top of that, too, some of my trainings I did back when I was living in Ohio was through the STAR Behavioral Health Providers, which was a really great experience for those of us who are civilians and aren't fully immersed in the military or veteran world and truly understand it. So I think that's such a valuable thing for us that are civilians, too. So moving on to objectives, because we don't need to stare at my face twice on the screen. So for today, a lot that we're going to talk about is just being able to describe the impact of shame from military sexual trauma, or M.S.ED. That's a quicker way to say it. Talking about some data and stats as well, and how we can support our male active duty and veterans. So, kind of jumping in, I'm sure most of you have heard of military sexual trauma. This isn't a new term or anything new that super new you're learning, hopefully. And if it's new to you, great. So with military sexual trauma, or M.S.ED, it's defined in the U.S. Code as physical assault of a sexual nature, batter of a sexual nature, or sexual harassment that occurred while a veteran was serving on active duty or active duty for training. So what that can look like, a multitude of things. This is just a short list, right? So being pressured or happening against your will, being overpowered by someone or multiple folks, unable to give consent. This is when I hear common that maybe they were asleep, maybe even passed out from using alcohol, or just asleep, as well as being under the influence of a chemical such as alcohol as well. Unwanted touching, threatening, and unwelcome advances, repeated and offensive remarks about your body or sexual activities. And the perpetrator might consider this as a hazing ritual. Working with a lot of young adults here, especially our young men that are active duty members, we hear a lot about quote unquote hazing, which, really is abuse of some form, whether it's physical, emotional, but also sexual. So that's something to certainly keep your ears peeled for when we talk about hazing. So this slide, in my opinion, lacks a lot of data. I'm sure most can agree that there's a lot of underreporting when it comes to this topic in general, but especially with men. So the data that I was combing and looking for, nothing is super, super recent. So I think this data comes back from 2022. So that's 3 years old now at this point. So it'd be interesting to see if there's any shifts or pivots around that in the past 3 years. What we find is, amongst women, 1 in 3 service members or veterans report having military sexual trauma, while men, it's 1 in 50. I think that number is way off, especially for the men. And even on here, I know that experts do believe that these reports are underestimated because of members not reporting this and what's going on. So I know there's more stats around the women, like I note on here, but it is important to note that 40% who report M.S.T to the VA are actually male veterans, which is pretty staggering. So kind of talking about a little bit more what I see here, because I really like to talk about real life cases that walk through our door. So we are a census, we keep around 26, 28 patients in total, kind of split that between men and women. So in our men's dorm, you're looking anywhere from 14 to 16 young men that we can have in there. Of that 14 to 16 young men, we might have 5 that are active duty at least. Sometimes it's pretty split. Sometimes we have more. So let's say we have 5 active duty service members in our male dorm right now. I can almost guarantee you that at least one of them, or if not 1, 2 of them, have some kind of military sexual trauma. So that right there is telling me at least 1 in 5 that might walk through our door. And that's a rough estimate, right? That can ebb and flow. But I can pretty much guarantee that every time a young man who is an active duty service member walks through our door at the Claudia Black Center, they have some history of military sexual trauma, whether it's something that they might deem as physical and like very clearly defined as sexual trauma, and some who will try to minimize it and undermine it too. So with that being said too, I think that there's a case that comes to mind that I worked with when I was a therapist before I became clinical director here. Very military heavy at the time and of our caseload that we had. So I had this young man, probably 25, 26, who had went through multiple M.S.T experiences. So the branch of service he was in the Navy and aboard a ship. So for him, he was really kind of confined and stuck on this ship with his perpetrators around him. And what his job was, it was kind of more behind the scenes, but it was the same crew that he was with every day. This young man sticks out in my head even years later, just because of how much it's impacted his life. So you might look at this young person before the military and would say like, oh, he identified growing up in a very supportive family. He personally had no history of any kind of addiction himself, and neither did his family. Really kind of like a promising young man, really looking to be in the military, and really getting to know him. Like, he really never had a history of mental health issues, period, whatsoever. So when he walked through our door, this was the first time he was actually seeking treatment outside of the mental health clinic on his base. So with that in mind too, the way this young man presented, he was extremely disconnected from his emotions, very disconnected, detached, I would even say. Wasn't quite dissociated. He was very much in reality, but just could not connect that mind and body. And we know how important that is when it comes to trauma. So he was extremely suicidal. That was kind of the piece that got him into our level of care, because we are inpatient, high level of care. really didn't see the point of living. And he was expecting a child, had a relationship. So bigger picture, it's like, well, there's all these wonderful things maybe going on in your life right now that are working out for you. But because of this trauma, it had set him off so deep into his depression. And that's really how he presented, was very, very much like depressed. What's the point of waking up? What's the point of getting out of bed? What's the point of just being here? So our program is a 45-day program, and because of how severe and persistent his depression and SI, suicidal ideation, was, we actually were able to keep him here, I think, for over 60 days because it was so severe and impeding on his life. Once we really started getting into the root of what's going on, right? Because he was the wall of pleasant, I would say. He would show up. He was one of my best patients, would come to all the groups, really engaged in group work, individual therapy, but underneath it all was this intense depression and suicidality. So once we really started digging into the trauma work more, getting him stabilized and everything, that's when it really came out about the sexual trauma. He did indicate this a part of his admission summary and everything, like our screening that we do. However, the depth of it was not all in there. So once we started getting into it, started really learn how intense these intrusive thoughts and images were affecting his life, amongst other trauma experiences he had occurred that weren't of the sexual nature. So he was already very vulnerable from the military sexual trauma, and then experienced a couple other traumatic experiences during his time. He was very grateful that his mental health clinic and who he was working with really had his back, were really supporting him, advocating for him. However, he would probably, using his own words from the past, would say the system failed him. He had gone through all the judicial processes for both of the assaults, and everything was just denied by the other party. Everything was dropped and everything had failed him, per his words. And this young man was forced to stay on this naval ship with his perpetrators for, I forget how long. It's, like I said, it's been a while since I've worked with this case, but was literally stuck. And so once he finally got back to the base, started seeking those services, he was able to come here and do some of that work. And I say that as like, that was a point for me as a clinician of like, damn, this is big. This is happening a lot more than I realize, and the severity of it as well too, especially with seeing these young men come through our door so consistently from the military and seeing how they're showing up. So it's the title of this presentation is Breaking the Silence, right? Because this is one of those silent killers. We can name many silent killers of men, especially military and veterans, but this is absolutely a silent killer that plays into those suicide ideations and suicide attempts as well. So as I move on to talking about more of these signs around military sexual trauma, my hope for all of you as you're listening is maybe you're taking a moment to think about maybe a client or two that you've encountered at any point in your career, or if there's anybody recently that has come through your doors and how that has showed up for them and how you've been able to support them, and how you've even assessed for that, right? Because especially with working with men, they tend to keep quiet and don't really want to go there until they actually have to. So some of the signs I have listed up on here, and interesting looking at them, right? Because they look a lot like other diagnoses, just your run-of-the-mill depression or anxiety or just some trauma experiences. But talking about anger and irritability, shame, feelings of failure, feeling damaged, that's a big one I've heard a lot, just feeling like they're just broken beyond repair. And that's so heartbreaking to hear. Concerns about masculinity or sexual orientation. So with that one, there's a bullet point off to the side. We're human. Our bodies function and do things sometimes without us intending to do that. So men have had those concerns of like, well, my body responded to that. Now, what does that mean about my sexuality? And then that reinforces the shame. Like, did I like that? I didn't ask for it, but my body's telling me that I liked it, but I did it. So there's that kind of dissonance and confusion with that. Increased anxiety and panic, increased depression, isolating and avoiding. That's what I saw a lot with the young man that I was working with. Obviously, a lot of increased depression, but also a lot of isolation and avoidance. his coping skills, that young man I talked about, was when he was on base before he was able to come to treatment, he would stay in his barracks. He would play video games, just binge out on all the sodas and candies, all the junk food, and just hide in there. Obviously, he would report for duty or work or anything he had, but in any of his spare time, he spent a lot of that time isolating. And that was how he was coping with it at that time. Sleep disturbances, somatic, so anything related to pain or digestive issues. And then poor self-image and eating issues as well, too. So, I think a common symptom I've heard a lot of any sexual trauma, men, women, military, non-military, can be overeating sometimes to kind of protect themselves, like putting on that armor, wanting to eat so much that they become repulsive to others so that they won't be harmed again. And obviously that's a form of self-harm for themselves too. They're not taking care of their bodies. They're putting all this junk in their bodies and gaining weight, and who knows what that's doing to their physical health overall. Other considerations, like I've added off to the side, feelings of denial and shock. I think that was a big thing I saw with the young man I worked with. Like there's part of him that accepted that this had happened to him and it wasn't okay. But then there's this part of him of, how did I let this happen? I can't believe this happened to me. Like, there's no way. And so that denial and shock I make up is really what kind of prevented him from really talking about it sooner rather than later and really getting into that deep work around it. I mentioned to you, men have those uncontrollable biological reactions. So that plays in, like I said earlier, to their sexual identity or masculinity. And then age, race, sexual orientation, religion, and previous trauma can really impact that person's response to it. So, somebody who's had experienced trauma in their childhood or in different ways, they're more vulnerable to a military sexual trauma response. So maybe they're going to have even more suicidality, or maybe their symptoms are so intense that they're having night terrors, they can't sleep at all, intense flashbacks, and just generally feeling unsafe. And then common what we see here, again, not with the young man I worked with, is, a lot of them will turn to something like alcohol as a self-soothing mechanism, maybe to help put them to sleep, help, get rid of those nerves that they're feeling. And so now we're building in that addiction piece of alcohol use. The young man I worked with too, talking about, race and everything as well too, he was a minority. So I think that also had this layer of disconnect, I guess I want to say, but there's this other piece that just kind of kept him from being vocal about what was going on. A lot of that machismo too, based on his culture. So he can't look weak, right? He has to look strong. He's in the military too. So adding all that on. And then, like I said, to increase suicide ideations. So pausing for a second, I'm curious if you're thinking of a person, a client that's walked through your door, service member or veteran, what did you notice with that person? And if they experienced military sexual trauma, and maybe how did you support them? And don't be shy.
Hi, I'm Sheila from Sacramento, VA.
Hi, Sheila.
Half of my caseload is devoted to M.S.ED, so
Wonderful.
I see both men and women. However, one case in particular has been tough, and I've seen him for a few years now, but a Vietnam vet who, everything, just all of the social implications of, males and, now he's in his late 70s and everything. So he's been married for 45 years and his wife still doesn't know. I think 2 therapists are the only people on earth who know. And so just shame is something that, we've tried to work on, the most, right? Adaptive disclosure type work. But yeah, it's a tough one. He trusts me And I think he takes the information and the validating and the normalizing and the biological responses that you were just talking about. But still just this, layer of it's not okay for him.
Yeah. Yeah, I appreciate you sharing that. Thank you. And I think that makes a big difference too, like that piece of talking about like age, like that generational difference too. So I'm seeing young adults, right, where there's a little bit more less stigma around mental health and trauma. But, my father is a Vietnam veteran himself. It took him forever to seek any kind of therapy. He was 70, I think, by the time he started going to treatment. So that generational piece is so huge because there is that, kind of don't talk about it. Like we have to look tough, and mental health, that's fake. Not really fake, but that's kind of how some of them might look at that. And then I see there's some comments going to, I saw somebody share too, like inconsistent attendance of, oh my gosh, my mouse isn't working, forget that. But inconsistent attendance of treatment or going to sessions. That's, that pattern. And then somebody shared feeling similar to what Sheila just shared. Let's see if my mouse wants to work. There we go. Any other examples that you can think of that come to mind from your own experiences? Oh. Hello?
This is Holly Kirstener from Telebehavioral Health. Hi, can you hear me?
Yes, thank you.
Yeah. I think this is so incredibly simple, but I think one of the things the screeners that we ask about childhood abuse, including sexual abuse and any history of sexual assault for all male patients. I think I've had a number of male patients who say no one's ever asked them, right? Because they like leave off that screener. And then just one additional thing about concerns about sexual orientation or masculinity. Based on past trauma work with children, one of the things that we would do is cut onions with kids who experience sexual abuse and talk about kind of the body's response of your eyes watering and not being sad, but crying and not having control of it, just as a real tangible way to kind of illustrate that our bodies sometimes do things that aren't in line with our desires, and normalizing it by noticing it in a more kind of kinetic way that's unrelated to sexuality.
No, that's a really great example. Thank you. That's an analogy I would love to use actually. So thank you for sharing that. So anyone else have any other thoughts? Going once, going twice. All right. I'll move on. Obviously, if anybody has anything else they want to add, please feel free to do so. And I'm also glad you mentioned about the screener of not asking men certain questions. So it'll be interesting when I get to this little short video that I have, literally a minute long. It's very interesting. It says a lot, I think, about how maybe men have been perceived, but also knowing that men might not want to speak up. So, and let's see if we want to go. All right. So talking about the impact of shame after a military sexual trauma. So I'm sure most of us are familiar with the term shame. I know at the Meadows, that is a hallmark of the treatment that we do around any trauma is shame, but especially when we talk about sexual trauma, it's a huge piece. So shame, by definition, one of the many definitions, shame is a painful feeling associated with the belief that who you are is not good enough, that you are inadequate, you are not worthy, and you are not of value. So shame is really the belief of like, I am a bad person. I don't deserve good things to happen to me. And so when I talk about seeing young men like this, one thing I know consistently or notice consistently with our active duty service members, and especially the young men who have the military sexual trauma, it's like a very heavy presence of shame. And if you work with shame, you know I'm saying heavy very intentionally, because shame can feel very, very heavy for someone to carry around. That kind of somatic response and feeling to it, and how it really is impacting their day-to-day to function. I see that with my past patient I had, like he was so depressed, and that's a very heavy depression. And that's the only way, you know, sometimes how he can kind of describe it, like this sludgy feeling in his body, just kind of weighing him down with so much shame. One of the hallmarks of shame listed on the slide too is talking about that self-deprecating inner language. So, you know, we might call those cognitive distortions too, if we're looking from that CBT standpoint, but also just being able to identify that negative self-talk and somebody who might have that really negative self-perception of self, that's going to be probably a big sign of shame. Other ways shame can manifest. So I know in the chat, I know Laura, you mentioned talking about addiction to porn. So just addictive behaviors, period, right? Whether that's a behavioral addiction like pornography. The young man I worked with, I probably could say, hey man, you're addicted to your screen and video games. Maybe not a substance, but you're certainly engaging in some kind of continuous behavior. A lot of the young men we do see here too struggle with alcohol use. Like that becomes their coping skill, and they're in that addictive pattern with alcohol use. The need for control and perfectionism, I feel like those go hand in hand sometimes, especially with our active duty men. They, because of all the training they do through basic and their jobs and what they are assigned to do in their role, there is this need for perfectionism and control. And when we're not in control, we don't understand what's going on and how to work with that. And here we are, shame. A lot of rage. Rage can be pretty quiet too. I know one thing we talk about with our young adults here is, you know, it's okay to be angry. Angry certainly is an emotion, but rage becomes a behavior and can also be addictive. So a lot of the young men we've seen who've had some of this MST, or just, you know, a lot of the shame that they're carrying from it, the rage can come out very sideways sometimes, maybe not always that physical aggression, but that rage through their mouth and what they're saying and spewing at that time. Victimization, that's another one. We see a lot of this here. So I just keep saying we see this, but so the victimization is a huge one too, and getting stuck sometimes in that victim spot. Like you can't get out of being a victim and allowing yourself to heal, and maybe you feel empowered. Procrastination, that also ties in a lot with, I think, perfectionism as well. Procrastinating, self-harm, a lot of that self-injurious behavior. Maybe that self-harm isn't the intent to complete suicide, but a way to cope or release the pain that they're feeling, because that emotional pain can feel so hard to comprehend and heal through, when emotion or physical pain we can see and feel and understand. Depression, and again, suicide ideations and attempts. So I think one of the biggest things that I take away from this, and maybe you already know this, or maybe this is something just to kind of reinforce how important this topic is this is a risky topic. This is a risky situation. This is a high-risk patient who might attempt to end their own life, whether it's through overusing alcohol or a substance as a means to overdose and destroy their body to die, or other ways they attempt suicide. And even engaging in self-harm. If they're not engaging in self-harm to complete suicide, maybe they are self-harming to a point where it is causing some serious risky damage that can lead them to maybe an accidental attempt. So I have a video from Brene Brown. It's very short, like I mentioned, but I thought it was just so pertinent to this topic and talking around men. So if you know anything about Brene Brown, you know that she loves to talk about shame. And I was trying to find something that really kind of captured shame with men. Obviously, this isn't specific just to like military or veterans, but I like this little short video. So I'm going to play it. If you can't hear it, please let me know. I'll try to make sure this is up loud.
For men, shame is not a bunch of competing, conflicting expectations. Shame is one. Do not be perceived as what? Weak. I did not interview men for the first 4 years of my study. And it wasn't until a man looked at me one day after a book signing and said, I love what you have to say about shame. I'm curious why you didn't mention men. And I said, I don't study men. And he said, that's convenient. And I said, why? And he said, because you say to reach out, tell our story, be vulnerable. But you see those books you just signed for my wife and my 3 daughters? Yeah. They'd rather me die on top of my white horse than watch me fall down. When we reach out and be vulnerable, we get the shit beat out of us. And don't tell me it's from the guys and the coaches and the dads. Because the women in my life are harder on me than anyone else.
That's what you want to do.
So I started interviewing for men.
So that was I know it's a very short clip, but in that 1 minute, there was just something about that 1 minute. I watched it several times last night because it was just, I don't know. I felt like there was a very powerful message in that, right? Like that dad giving that example of, see those books you signed for my wife and my daughters? They'd rather me stay on that high horse or die on that high horse than be vulnerable. Like that's been reinforced, right? And even when she talks about like, oh, I don't study men. Oh, that's convenient. Like, yeah. So there, like she said there too, it's that perception of being weak. And I think just in general, talking about men and mental health, that is a concern I've heard across the board through, I worked in community mental health, private practice, and inpatient. I've heard all of that from men of various backgrounds and sexual orientation and everything in between. And then add this to a service member or a veteran. I can't tell you how many times a male service member will come in here and say, I have to be strong. I can't look weak. And I'm not even kidding when I say it's literally every male active duty service member we see here. That is their perception of how they need to show up. And so many of them carry so much shame about looking weak. They don't even tell some of their closest friends or family that they are in treatment here because of how they fear they'll be perceived. I remember there were several of them that I'm like, who can you call like while you're here to like seek out some support, friends, just kind of assessing their social supports. Well, I can't tell my brother and I can't tell my mom or my dad. I talked to my sister, but I asked her to keep it quiet. And, nobody in my unit knows I'm here. They just think I'm on another event or assignment or something like that. And that was their choice to share that way. But that speaks to me about how much shame men carry and their fear of looking weak. So now layer that in with the MST, and they're coming to us as clinicians. And are they going to be open? That's my hope they will, that they know it's a safe space for them to be vulnerable and really talk about what's going on. But that's a huge fear, right? Like, are they going to be open? Because how can we help this person not only heal, but stay safe, knowing that there's a lot of risks that come along with experiencing MST for an active duty service member. And I think I kind of summarized the slide as I've been talking about it, but talking about that stigma that comes along with men struggling with their mental health, their trauma, suicidality, the greater stigma for men in the military, even just in general, male service members finding it hard to seek out treatment. Great, they showed up to your door and they're in your office, or they showed up to our treatment center. Thank God they're here, but how long did that actually take them to get to that point? My bet's at least a few months, maybe longer, unless there was maybe a recent suicide attempt and they're kind of mandated. But if they're coming voluntarily without a mandation, how long did it take them to get there? The young man that I talked about that I had worked with, no history of doing mental health treatment at all until these MST situations happened. And even then, like, I'm pretty sure he waited months before he even sought out treatment to address what was going on with him. And I'm pretty sure he also waited months to even report it too. So even just the piece of reporting it to authorities who can bring justice to the perpetrator, that's not being reported either, right? They're not going to that person. And then the last part too, like I mentioned about the young man I work with, is a lot of them, in my experience, right? I don't want to overgeneralize, but in my experience, there's been that general thought of the system failing them. That, okay, well, I reached out and they still screwed me over. Now what? Might as well just go end it now. Getting screwed over, and how can they face going back to their unit, not being taken seriously? And that just continues to reinforce that shame. So I'm curious too, not to put everyone on the spot again, watching that video too, and just talking about that stigma with men, like what stood out to you from that? And Esther, I see your comment of the women in my life give me more crap than the men in my life. Yeah.
Hi, this is Sabina. I'm from the JBLM, Seattle, Tacoma area. And I thought when I first heard that too, my first thought is I hope we're growing in this area. And historically, I think as protector, I think for me, looking at my father versus the growth that my brothers have experienced, my brother was in the same blue collar job as my dad, I see improvement. And I'm hopeful that that's what we're starting to see in the military, although lately I have concerns, but I do think that's part of, as women, I'll speak for myself, right? I grew up as my dad as my protector, and definitely my grandfather.
Yeah.
And I see my daughter, who just had a child, raising him to be able to speak about his feelings, to speak about other people, and speak about how, I'm just hopeful that it's improving.
I appreciate that. Thank you, Sabina. And I agree. Like, I try to remain hopeful and optimistic about it too. My dad is also my protector, and I think that's kind of a lot of that dialogue that I've witnessed with some of our young adults too, that the male person in their life has been their protector and their strong one. But I also, from where I sit, right, I see a lot of hope that we do see so many service members coming in our door, more men than women, actually, which I think is, hopeful, I guess is the best way I can put it. Like, I'm hopeful and optimistic about it, that they're willing to come to treatment and try to get vulnerable, whether that's through talking about M.S.ED experiences or other experiences. But thank you. And then I see
Also,
go ahead. I'm sorry.
I just wanted to add to that. I work with transitioning soldiers. I'm actually on site. I'm with the VA, but I'm on site at an IDES building.
Yeah.
I ask all of them as part of my assessment if they've ever experienced military sexual trauma, male and female. And I know a couple of the other VA workers that work with transitioning soldiers also do the same.
Yeah. Thank you. And I'm glad that you are asking those questions and people are asking those questions, because I think every service member needs to be asked that, for sure. I see in the comments too, some are quicker to ask women if it happened to them compared to asking men. Yeah. And so maybe even sometimes us professionals or even just other folks might just assume it's happening to women more than men, when really there's probably a lot more men out there that we're not even aware of. I shouldn't say probably. I know there's a lot more men out there that we're not aware of who's been affected by it. All right. Any other thoughts? Because I see we're already at 12:40 and got a few more things to go through. All right. I'll move on. And thank you for those who have shared in the comments and spoke up. I appreciate that. So the last piece I really just want to talk about is healing shame. So in general, we would just say, oh my God, shame reduction work. Cool. What does that mean? Shame reduction work might look very different for each individual and how you approach that with them. But at the very least, it's being able to identify the shame. And I mean, that probably starts even with identifying the trauma and the piece that's leading to what's showing up for them, and providing therapeutic ways to maybe challenge some of those shame beliefs. We'll go a little CBT for a minute. We know that as challenging our cognitive distortions, right? Trying to challenge that and reframe that, do some cognitive reframing there. But that can also be like pretty cerebral. We want to kind of get them in their body a little bit. That's how I look at it. I like that somatic work. and finding different ways to really process their shame and release that shame too. So even just some basics of helping that individual build some self-compassion for themselves, talking about that biological reaction a male might have during the MST is that there's shame, like, did I like that? No, let's have some self-compassion. I love the example earlier again about the cutting the onion, right? How do we build self-compassion with that? Like, our body does things, and that doesn't mean you like that, or that doesn't mean anything different about your sexual identity. Resilience building, helping the individual through different modalities to build that resilience, right? After somebody's experienced a little trauma or some trauma, we want to look at that term post-traumatic growth. Like, how can we grow from here? Obviously, this person is hopefully stabilized and not in active like self-harming or suicidality, but building some resilience from there, learning different skills even. DBT is something that we use a lot here. I use that in private practice a lot. I think DBT is so powerful for self-acceptance and compassion too, of having that radical acceptance, kind of like riding the wave, being mindful, like respecting the emotions that come up for us. That all kind of ties into that compassion and that resilience. Like, we're going to have emotions, and that's okay. And how do we flow with those emotions? Affirmation work, I think, is extremely powerful. We start affirmation work almost day one with our young adults here. Most of them sometimes will get like little clickers to count how many affirmations they'll do a day, especially if they really struggle with that self-deprecating dialogue and those negative thoughts about themselves. Having them practice affirmations, journaling them, saying them every day, a part of a session, closing out a session, or if you're working in a situation where you're doing group therapy like IOP, PHP stuff, starting and ending with affirmations as part of the group too. Inner child work, I think that's really dependent per each person, but I think personally, from where I sit, I think inner child work is so powerful. Even if somebody doesn't have true what they might define as trauma from their family of origin, because we know other research around shame shows that shame starts in our childhood and it's usually given to us. We don't just wake up one day in our adulthood and suddenly have shame. It's something that's been reinforced through our experiences in childhood. And it doesn't mean that maybe the caregiver or parents had some horrible physical sexual abuse to that child, but just the messages that were, shared, even just simple messages of, you're being a bad boy, you're being a bad girl. My mom and aunts love to say, you're a bad girl. Well, that just gives me shame, right? So I'm carrying that shame. And so somebody who might have experienced even stuff like that in their childhood, like, how does that carry into their adulthood? And if they've experienced that MST, that shame's already there. So doing that inner child work, a lot of the work we do here at our facilities at the Meadows is very experientially based, very much empty chair Gestalt type of work. So being able to release the emotions and reparent that inner child. Empathy and connection is huge. So obviously helping, giving empathy and compassion to that service member, hopefully instilling in them empathy and self-compassion for themselves, and also connection. What does their support system look like? What does their support groups look like? The power of a peer community. That's, the work that I see in my program. It's largely group work, also with individual work, and that peer community and power of building that supportive community is so helpful in shame reduction, because it's helping them connect with others of, oh my God, I'm not the only one. There's other people like me. So I'm not just some weirdo little outcast over here with the worst thing ever. Like, I can connect to people who are experiencing the same stuff, and there's hope for me with that. Usually you find more hope when there's that peer connection, because they see maybe somebody else who's made a little more progress in their healing and recovery, and, oh, there is hope for me. Self-care, I think, is also very basis of a lot of this too. Like, how are they taking care of themselves? If somebody's struggling with sleep, are they trying to prioritize some kind of sleep hygiene routine? Somebody who might be struggling with behavioral or even substance addictions like alcohol, pornography, gaming, video gaming. Okay, so how can we have some boundaries around that and practice other self-care, like going to the gym, going for a walk, reading a book if they love reading, journaling, calling a friend, making time to spend time with individuals if they can. And then, of course, mindfulness practices. I know I kind of talked about that as well, but mindfulness, I think, is so huge in helping build all those other pieces of resiliency and self-compassion to be respectful to ourselves with mindfulness. And a lot of the principles I love of mindfulness is acceptance is one of those as well, too. And learning how to just be with our emotions and be present. And I did want to note on the slide too, safety is a priority. I think I mentioned too, like I'm assuming somebody is coming to me that I can do some of this work if they're in a safe space, because if they aren't safe and ready to do that work, stabilization, of course, is the first thing to look at. And I always like to add into shame is not a direct reflection of self-worth. And then a simple little closing piece of like, how can you help? And I think this can pretty much go without saying, but first and foremost is creating this safe, non-judgmental space for the service member to come in and build that rapport so they feel comfortable with opening up and sharing. I know the young man I talked about, it took us probably a good 3 sessions before we really got into the nitty-gritty of all the MST he experienced and how deeply it was impacting his life. Active listening, of course, empathy, empowerment, engaging in that shame reduction work, and being an advocate too. Ways that we can find ways to advocate for that person. Maybe it's not that easy in some cases, but how can we advocate for a person? I know in my experience where we work here with inpatient and working with service members, the way we really advocate is with their mental health clinic and their base. Hey, this is what we're seeing. We really want to advocate for them to have some continued work around XYZ, and how can you support that? And that's how we try to advocate on our end. And thinking of how can you advocate on your end for that individual too. And I'm very fortunate that we get to work with so many wonderful bases at CBC with the young adults. And we've had so many positive experiences of those mental health clinics and other bases, like really advocating for the service members with the pieces that we give them. So thank you, all of you, for all the work that you do, because it is so important. And that is all that I have. So I know there's 10 minutes left. And I see one question from Sabina. Do you provide additional training on this topic? I would love to. As of right now, I don't, but I would love to. I don't know if anybody else through the Meadows does too, but this is something I'm very passionate about. Any other questions or comments before we come to our wrap for the day? And if you think of questions, you can put in the chat. Oh.
Caitlin, do you have any
Yes.
more case studies you can provide for us in the last 10 minutes?
Trying to think of one. Thank you, everyone, for the kind words. I know we see a lot of women, almost all of our women come with military sexual trauma, but we do have a young man right now who came, I believe, from an overseas base, if I remember correctly. And that was a big piece of what drove him here. I will say, thankfully, he is extremely engaged and extremely open to do the work. And this would be a different case too, where he does identify as gay. So how that is impacting him, and even just like intimacy and connection, right? I don't work with him personally, so I can just give kind of the basics about him too. But he, especially with some of our gay service members that have experienced MST, I think a big thing that I've seen with individuals such as a current patient we have is like connection and feeling safe in a relationship too. So is that something he is struggling with, to be able to feel like he can be safe enough to be in a partnership or even some of those friendships as well? So looking at those social aspects too. I see a question about the Claudia Black program separate from Gentle Path. Yes. So we are specifically young adults, 18, and I said like up to 29, 30. We've had young adults that age. And we do program very gender specific. So it's almost like 2 programs under one roof, where the men are in their own programming with their own therapists, and literally their therapists are attached to their dorm, and same with the women. And at any given time, I'd say 40 to 50% of our caseload is active duty service members. And we find with our service members in our age program compared to some of our other programs are able to connect with other service members their own age and even civilians their own age to really kind of build that peer connection and community. But we do have some differences. I know Gentle Path is very focused on the sex addiction piece. We do see some of that here, but if they're very severe sex addiction, porn addiction, Gentle Path might be the better option. But I'm working on my CSAT as well as another therapist. So we do also work with some sex addiction if that's part of their makeup too. So good question, Jerry. And I don't think I have anything else. M.S.ED program. Okay, so yeah, for older adults, we do have the Meadows flagship campus, which is all adults really. So they do screen out like who's appropriate for the young adult program, but we have the Meadows flagship campus. And then there's Willow House and Gentle Path, which are two other programs that see adults of all ages. So it really is depending on the service member and what their presenting issues are. But somebody with sexual trauma, maybe the Meadows, the flagship campus, but that would depend on their screening and what's going to be best fit for them.
We also have our Willow House program that's for women with a history of relational trauma that works with the same population with M.S.ED. That's the sister program to Gentle Path, which is for male with sexual compulsivity. And then as Caitlin mentioned, our main Meadows campus. And your assigned clinical care liaison with Meadows will be able to guide you and give you some more details on each of the programs if you want to staff any case with them. If for some reason you don't have contact with your liaison, I will put my email in the chat and you can message me and I will connect you gladly. Thank you.
Thanks, Bianca.